The nonprofit MBA purpose is to provide new business insights and fresh creative ideas for executive directors and their teams that will help them improve their organization. Here is your host, Stephen Halasnik.
Welcome, everyone. My name is Stephen Halasnik. I will be your host for today's Nonprofit MBA podcast. And for those of you who don't know me, I am co-founder of Financing Solutions. And for the last 15 years, we have been the leading and largest provider of lines of credit to small nonprofits in the United States. It's a great product, and if you're interested in learning more about it, please feel free to visit our website at nonprofitmbapodcast.com. Today, I am very excited to be speaking with Dr. Aponte from East Harlem Council for Human Services. And today we're going to be talking about how to address your nonprofit's financial challenges, which is a great conversation for especially now. I mean, it's always an issue, but certainly in the last year and a half, it's been more of an issue. A little bit about Dr. Aponte. He's the CEO of East Harlem Council for Human Services, a leading nonprofit organization dedicated to delivering high-quality, community-based healthcare and social services. A lifelong advocate for health equity, Dr. Aponte has spent his career improving access to care for underserved populations across New York City. His leadership in East Harlem continues to shape how nonprofit, community-driven health initiatives can create lasting, meaningful impact. And we're honored to welcome Dr. Aponte to today's show. Welcome.
Thank you, Stephen. Thank you for inviting me to join you and your audience and take part in this conversation.
So, I guess the big elephant in the room has things been any different in the last year and a half in regards to financial stability than it was prior to the year and a half ago?
Yeah, absolutely. I mean, well, that's a very loaded question. So, we are, just to give context to your listeners, our organization, the East Harlem Council of Human Services, runs several programs under our umbrella. We have a bilingual Head Start program that's funded through the Department of Education here in New York. We have a federally qualified health center, FQHCs. You'll be hearing me use that reference, which is a HRSA-funded health center that we've been operating for over 52 years in our community, that provides primary preventive care services to any individual that crosses our threshold, regardless of insurance, regardless of immigration status, you name it, we take care of them and to ensure access. We also have some school health programs where we embed our health services inside of elementary and middle schools, and we have a senior nutrition program for older adults. That's what older adults like to call themselves now, Stephen. Instead of seniors, they want to be called older adults. Or if you go to my center, they like to be called recycled teenagers. But anyway, so those are the four programs. And so to focus on two of those first programs, Bilingual Head Start and the Federal Qualified Health Center, FQHC, we've seen significant threats to our funding. And so this is a big challenge that we're facing over the last year and a half, such that for our Bilingual Head Start program, which is funded through the federal government, we saw a paucity in funding this last year. And so much so that we thought we were going to close our program after 57 years of serving the community. Fortunately, here in New York City, we got a reprieve from our new mayor and governor, who are investing in early childhood care. And so we're fortunate that we do have some funding, at least through next year, but we need long-term funding. So that's one of the issues that's coming down from the federal government that normally supports these programs. And then with our FQHC, the biggest issue has been HR1 and the changes in terms of Medicaid and how that's going to impact. We serve a very large Medicaid population. Over 65% of the individuals who receive services at our health center are Medicaid recipients. Another 10% or so are uninsured individuals. And so with HR1 and the changes that are coming through HR1, we're going to see a significant drop of individuals from the Medicaid rosters, which means more individuals will be uninsured. And as I mentioned, our health center will continue to see these individuals, but there'll be no revenue tied to these visits. And that's creating a gap in what's already a challenge as far as revenue for FQHCs and health centers like ours. And so that's a significant challenge that we've been facing and we've been trying to advocate at the city, state, and federal levels to address. Otherwise, these gaps are going to create causes or pauses in our programs, rather, limiting the programs and what we offer, the services we offer. And some FQHCs may actually close, right? And so that's going to even further the gap as far as access to care for primary preventive care services. So that's a big issue, headwind that we're facing today.
Wow, it's unbelievable. So let's maybe we could get some context. What was the annual revenue of your organization prior to a year and a half ago on a yearly basis?
Well, the way I would look at this, Stephen, is what revenue we anticipate will lose as a result of HR1.
Yes, yeah.
So when you look in New York State, there are 80 FQHCs with about 900 locations. We take care of 2.5 million New Yorkers. That means 1 in 8 New Yorkers get their care in the FQHC. And as a result of HR1, we anticipate that collectively we're going to lose $300 million in revenue. And that's very conservative, sort of figures. It may be greater than that, but we anticipate a loss of $300 million. Added to that, in New York State, FQHC's reimbursement rates are based upon 1999 cost factors. So imagine, Stephen, a quart of milk in 1999 and what a quart of milk costs today. So today we basically get 70 cents on the dollar. So these two things additively are going to create significant funding gaps for us. And again, we're going to have to curtail services. We cannot continue to deliver all the services that we feel our communities need because we just won't have the funding to support it. For us at the East Harlem Council, we anticipate a loss of about $700,000 to $800,000 in revenue as a result of HR1. Which is pretty significant. It's not going to close our doors, but it's definitely going to have to make us pivot and think about what programs we offer and what staffing we can bring on board as a result of it, because, every penny is tight in the not-for-profit world. We operate on very, very tight margins already, and this added impact on revenue is not going to make things easier for us.
How has this impacted you personally?
Interesting question. To me, this has made me be a little bit more, excuse my French, but badass. Like, I grew up in a community of East Harlem myself and have faced significant challenges. So I work and serve the community that I grew up in. And I faced significant challenges as a young kid growing up poor in this community myself, and faced many challenges, even the challenge of people thinking I would become a doctor. And that has created a certain defiance within me that says, I'm going to prove people wrong. I'm going to show people that we can make a difference. And when I see cuts like this that continue to impact the community that I love, I become even more determined to make a difference. And so I've become extremely vocal on every platform, and including your platform, which we really appreciate having this opportunity to talk about our narrative, to talk about the work that we do, the importance of the work that we do to the communities that we serve, and why it is fundamentally flawed to be cutting services to communities like East Harlem. When we talk about fraud, waste, and abuse in the healthcare system, yes, some of that does exist. I don't doubt that exists. But this is not the place to be looking for that. That's not where it exists. And what you're going to further do is really hamper our efforts and drive people into more expensive care. Primary care in my facility is much cheaper than when individuals go to emergency rooms and get admitted to hospitals. That drives up the cost in urgent care. Those things drive up the cost of medicine. And so we're focusing and putting the emphasis on the wrong part of the healthcare system, where we should be bolstering organizations like ours. And so I will talk to anybody who will listen. I've gone up to Albany. I've gone up to Washington, D.C. I talk to as many individuals to make sure they understand the true impact of the work that we do, why we need to be supported. We're not looking for a handout. We want to continue to serve these individuals who otherwise would not have access to care were it not for us. And we need the assistance of our legislators and our elected officials to continue to fulfill our mission.
How has it affected your staff? I mean, what have you noticed? How have they changed?
Well, they certainly are concerned, and I keep my staff very well informed, and I've activated them as well, right? I told we have a staff of over 200 individuals that work throughout our programs, and they see how active I am in terms of fighting these issues or raising these issues, and we've activated them. And we've created forums to have discussions around the work that we do. And so many of them actually have been on similar podcasts. They post on their social media. We've had them come up to Albany with us because as a CEO, people hear me and they're like, okay, you're saying this because you're the CEO. But when you hear from my staff directly and from my patients as well that we take up to Albany, it makes a big difference. So they've expressed concerns, but they also want to know what they can do to help make sure that we, have a viable organization that continues to serve in the important way that we serve. So they're in the same fight with me.
From a realistic standpoint, when you have gone to talk to either people at the state or at the federal government, and you've, talked to them about your organization and what's happened with cuts and how it's going to affect everybody, and what has been the reaction?
Well, it's interesting because one thing I will say about community health centers nationally, right? So nationally, to give context again to your listeners, community health centers, FQHCs, have over close to 1,600 sites in New York, in the United States, with many more sites than that, right? So 1,600 FQHCs, but they have like about 9,000 locations, serving over 35 million U.S. residents. And so there's always been bipartisan support for community health centers, just not at the level that it needs to. And what we find is that we continually are educating our legislators about the work that we do. They don't fully understand our work, the impact that we have. And so it's been our responsibility, and I think it is our responsibility, to make sure that we control our narrative and help them understand. And admittedly, these legislators get a lot of issues thrown at them. So it's hard for them to become steeped in what the issues that we face. So it's our responsibility to share with them. Once we do share with them, there's an obvious support for the work that we do amongst many of the legislators across the aisles. Some, again, still have misconceptions about fraud, waste, and abuse and things that, could be changed. And so we have to further educate them around that. But there's been that bipartisan support at the state level, at the federal level, at a local city level. But the appetite to take action is what's missing amongst many of them, right? So they say they want to support, but when it comes down pen to paper, they're not giving us the support that we need. And that's something that we need to really work on. And that's with the constituents. And that's why we've activated our staff. They need to start pushing these legislators to push it further. And we could talk about what's happening in New York State around some of those issues specifically, and where we've been able to push the needle, but we haven't gotten it to the point where we want thus far.
So, today's topic is how to address your nonprofit's financial challenges. So, if I understand you correctly, and to summarize, the first step is to fight back, right? Not to just, take it, just to fight back, not to let things steamroll you. Is that fair enough to say?
Absolutely. Advocacy, raising our voice, making sure people know the work that we do, what we're doing, the impact that we have, the return on investment that we represent more so than any other aspect of the healthcare system. Look, we represent less than 1% of the total healthcare expenditures in this country, but yet we take care of 10% of the population. Right, I mentioned 35 million plus U.S. residents get care in FQHCs. So we're doing something right to control the cost of healthcare expenditure. And so this is not a time to pivot away from that. So that's part of what we need to do, be very, very vocal around it. But it's not all, right? Because we also need to pivot ourselves and think about how we do business. And so, to further expand on your question and how do we sort of bridge those gaps is we are also a very siloed healthcare delivery system. We tend to work as competitors and not collaborators. So the health center down the block from me, instead of looking at them as a potential collaborator, how can we work together? How can we work on economies of scale? We look at each other as competition. This is my patient. That's a nonsense. No patient belongs to me, right? Our role is to serve this community, and what we need health centers like us to do is to start to work as collaborators, shared services, so we can decrease some of the individual costs. We all retain lawyers, right? We all have credentialing, people that help us with credentialing, a whole host of services that we purchase, that if we came together as a collective, we can decrease that cost and save some dollars at doing it at the same time, right? And be more efficient. So to me, and what I'm trying to do here in East Harlem is to get and scale it, quite frankly, is to get my fellow FQHCs in East Harlem, of which there are about 5 of us, to work more as a clinically integrated network and share expenses and share resources, create this process that I call no wrong door. Wherever a patient goes, they get the care that they need. And if I know that a patient is better served at a health center, another health center, then it's my responsibility and my duty to get that patient there and not worry about that patient coming to my health center particularly. So that's a paradigm shift in healthcare delivery that doesn't exist. And then bringing in other partners, community-based organizations that have an expertise that we don't. I don't do housing. I know how to refer people to housing facilities. I don't have a food pantry. I have a small food pantry, but people who have food insecurity, right? Transportation issues, all those things collectively are what we need to focus on to improve healthcare delivery, to focus on what I call whole person care. And if we do these in collaboration and not competition, we're going to be able to decrease some of that cost. And so that gap that I described in terms of revenue can be decreased by decreasing some of the costs that we incur as functioning health centers.
Take me back to the time when you found out that your funding was going to be cut, and how you and the board, what happened,
Yeah, there's been a couple instances, right? So the very first sort of attack on us, I believe it was January 27th, 2024, when we get a grant from the government. FQHCs get a 330 grant from the Community Health Center budget, which right now, the most recent budget for FQHCs in the country was about $4.7 billion, which, by the way, represented a $100 million increase from the past 10 years, but falls short of what we think we need collectively nationally at $5.7 billion, but a step in the right direction. On that date, there was an executive order issued to pause all funding allocations for 330 grants immediately. So I was in a conference and got this text or this email notification, and I was like, holy crap, what's going on? That funding for my budget represents about 15 to 20% of my annual operating budget. So that's not insignificant, and that would have really caused some significant issues as far as programming. Fortunately, there was an immediate stay a day later on that executive order, and it has not been issued. So that was the first sort of glancing blow or sort of shot across the bow that we looked at. And then HR1 came through. Leading up to HR1, we had a lot of issues in terms of what the language was in HR1, the misunderstandings around Medicaid, the new requirements as far as Medicaid re-enrollment, doing it twice a year versus once a year, which currently exists, eliminating the continuous coverage of children. I'm a pediatrician, right? And so Medicaid, when the child is born into Medicaid, they have continuous coverage until 6 years old, because we want to make sure that children, right, in early development get everything they need, right? All the immunizations, height and weight monitoring, the developmental assessments that are critical, that if we address early in life, we can sort of curtail the long-term impact of that. And so Medicaid in New York State allowed these children to stay continuously enrolled. That was impacted. right? The work requirement now for Medicaid recipients, able-bodied individuals between the ages of, you know, uh, 18 and 64, considered able-bodied, they have to either work, go to school, volunteer time, up to 80 hours a month. That's a part-time job. So all of those things was a real punch to the gut, if you will, for us as far as how are we going to continue to make sure our patients stay enrolled in Medicaid, since they have to do this twice a year. And it's not the most complicated application, but for individuals who are facing many challenges, it's not easy. And so we often have people help these folks with that applications. So not to do it twice a year instead of once a year. And if you miss that, by the way, you can go months before you get re-enrolled into Medicaid. Ensuring our children don't fall off the Medicaid roster to get the care that they need, right? How are we going to help an individual identify, volunteer work, vocational services, or schooling for 80 hours a week? I think most people, if they can work that amount of time, they would, but they're finding challenges in terms of the workforce and finding these opportunities. So all those things really represent was a significant impact to us, and is causing us to really think about how we're going to bridge that divide.
How would you say the stages that you and the board went through from that first announcement to the way it is now? Like, usually from what I had seen, let's go back to the COVID days, it was like a deer in the headlights first type of reaction. Then it was a little bit more about realization of what's happening, and then came a little bit more of acceptance, and then came action.
Mm-hmm.
Do you is that the same stages that you noticed that you and your board kind of went through?
Yeah, I think we went through those, but at a high rate of speed, right? Because we couldn't stay thinking about this too long. One of the things about community health centers like ours, we have to be very, very agile and pivot on a dime when these sorts of things face us, these issues face us. And so we don't, we try to figure out immediately what we can do to do differently. So first was like, okay, how does this impact? This is the reality. Let's make sure we understand what this bill is doing and what it's not doing, and had to educate my board. My board, by the way, for your listeners, are consumer, right? They are actually patients of my health center, 51%. So many of them are not very aware of these issues until we bring it to their attention. And so my job as a CEO is to make sure my board is aware of these issues and how they impact us. That's number one. Number two was, okay, financial impacts. Is there anything immediate we need to do? That's another reaction. How do we, what are the levers that we can pull to try to impact this, if there's any opportunities around advocacy, right? And then what are the business decisions we need to do differently to sustain ourselves during this time? And so one of the things that we're doing, for example, I talked about the partnership, working with other FQHCs on economies of scale and decreasing our costs. So that's something that we have, and we're moving forward. It's going to be a model that other people are going to see and look to replicate, we hope. The other one is looking at our lines of business, right? And so, as I mentioned, we're a big Medicaid provider. We're not such a big Medicare provider, right? And so how do we intentionally grow another line of business that can help augment that revenue loss in Medicaid? And so we're strategically focused on Medicare now. Most FQHCs, unless they're in what's called a NORC, a naturally occurring retirement community, don't have a great percentage of Medicare. Not that we can't take care of these patients. So how do we attract those patients to our health center, which is, for a health center, is a good payer, right? And so that's a good financial model for us. So those are some of the things that we've worked on. Fundraising, right? We try to do as much as possible. And so we embark on galas and try to get our partners to lean in with us, understand the work that we're doing. As a matter of fact, May 20th in 2026, if you're in New York City and you want to attend our gala, come on through and join us and see the work that we do the impact that we have and the vision we have for the future, and how you can partner with us, because philanthropy can help us to deliver on our mission. And in many ways, is actually a little better for us because it's unrestricted. We can be a little more creative. Many of the dollars that we get are very restricted and have to be used for very specific types of things. When we get unrestricted funding, we could be a little more innovative. So that's the process that we've gone through today. And, I'm happy to report that we're on stable ground at this point in time, but, anything can happen at any given time. And so, we continue to be at the ready to pivot whenever we have to pivot.
Have you found new revenue streams?
Yeah, so the big one right now is Medicare, increasing that. And then there's a couple of other services under the Medicaid and Medicare program that we have not fully developed that can represent revenue streams for us. Transition of care, that means patients who leave a certain care setting like an inpatient or nursing home, making sure that they transition smoothly back into the community, into primary care. This is where, patients who get discharged from a hospital with a chronic condition, if there's not a warm handoff after that, they can get readmitted into the hospital fairly quickly if they don't have the right support when they get out of the hospital. And so that transition of care time, there is an opportunity for us to give some additional services to patients and generate some revenue from that, doing some additional care management, managing chronic conditions on a more regular basis, not only at the health center, but talking to patients who have diabetes and hypertension. It's called the Chronic Care Management Program. That's a revenue stream that we can also tap into that allows us to work with patients, not necessarily in the health center, but even at home. So we can call you, your relative, or someone like that who's dealing with these conditions saying, hey, Stephen, make sure you're taking your medications correctly. Hey, Stephen, you have a follow-up with the specialist as a result of your diabetes. All these sorts of things, we do some intense care management. So that's a revenue stream that we are able to look into. And the last one is what we call remote patient monitoring, where we can actually monitor conditions remotely for patients, again, who have hypertension, diabetes, COPD, other conditions, so that we know when they're not in the health center how well they're doing. And through wearable devices, we can get an alert and say, okay, Stephen's blood pressure is pretty high today. Let me have the nurse call him and find out what's going on with him, because I might need to bring him in and adjust his medications. So those are a couple of revenue streams that we're looking to tap into that are very beneficial, and ultimately, by the way, will decrease total cost of care, because, again, keeping people out of the emergency room, keeping people from admitted to the hospital, and keeping people out of urgent care is really going to have a significant impact in decreasing the cost of care.
When you have your board meetings now versus the way it was 2 years ago, are they different?
They've evolved. I've been the CEO for this organization for about 2.5 years, and we have developed a good relationship, we being my executive team and the board, to really help them understand how they can help us to do our job, right? As I mentioned earlier, many of them are not steeped in, the work that we do, but are lending their time and efforts to try to help us achieve that work. And so the difference has been that there's a greater deal of transparency with us and the board, a greater deal of in-depth conversations about the work that we do, so there's a better understanding. So when they can offer up opinions, there's a lot more questions being asked by our board members, and we like that, right? We don't want board members just to sit there and accept our board reports and have no questions. A lot more suggestions. So in that sense, it has changed. They have allowed me to really get ourselves out there and increase the exposure of the health center so that people know more about us, and continue to find opportunities for us to, share our narrative with new individuals who may become supporters. So that's the way that it's changed over the last 2.5 years, and in a good way.
Cool. So we're running out of time. So the last word of advice in regards to how to address your nonprofit financial challenges, what would your last kind of recommendation be?
Well, don't do it alone. We can't do this alone. We really have to collaborate, and we don't do a good job of that in the non-for-profit world. I think we put our blinders on and we don't look to partners. And, I think that there's so many ways that we can help one another. And to me, that is what has failed our communities, this siloed approach to healthcare delivery. And it's also impacted our finances. So let's collaborate. Let's share ideas. Let's think about ways that we can work together. Those things I think are going to be very, very beneficial to all of us at the end of the day. And you know what? There's enough margin out there for all of us that we can share patients and work in this fashion without, taking anything away from one another. So I think that's really, really important. And control your narrative. Make sure people know the value and don't be complacent to think that people know what a community health center does. Share the stories of your patients, the impact that you have. Look, we deliver healthcare, but I told you I have a food pantry for 50 families every 2 weeks. I give away clothing from the health center as well, right? Those are other things that we're doing that we don't do a good job of sharing with folks so they can understand the full impact of the work that we do. And that's when people will lean in, and lend their support when they do know that. So I think that's the best advice I can give individuals. And for those who are in a position to support FQHCs, visit your local FQHC. Go see the work that they're doing and see how you can lend a hand. And it doesn't always have to be monetarily. There's expertise that we lack in FQHCs because we can't afford certain expertise, but having that expertise would be very beneficial to helping us deliver on our mission. So volunteering your time and efforts is equally as important as, writing a check.
Great. Well, I'd like to thank so very much Dr. Adam Aponte from East Harlem Council for Human Services for coming on today's podcast. And, if you like today's podcast, please feel free to share it with a friend and also subscribe on your favorite podcasting app for the Nonprofit MBA podcast. Again, if you're looking for a line of credit for your organization, please feel free to visit our website at nonprofitmbapodcast.com. Dr. Aponte, if anybody wants to get a hold of you, how would they go about doing that?
Sure. I mean, you can visit our website, which is www.borinquen. I'll spell that for your listeners, BORIKEN.org. By the way, the name Borinquen is the original name of the island of Puerto Rico before the Spanish took over. So we're very steeped in Puerto Rican culture here in East Harlem. You can follow me on LinkedIn. So just look up Adam Aponte, MD. I'm very active on LinkedIn. And I'm trying to get my Instagram game going a little bit as well. So A Aponte MD, you can find me on Instagram, posting there as well. So those are the three ways that your listeners can get in touch with us. And if you visit our website and you're in New York City and you want to come to our gala on May 20th, you'll see information about that as well. Thanks for coming on today. Thank you, Stephen.
So, everyone knows this adage, but it's, when times are in trouble, you put your own air mask on first in the plane, and then you help others. But many of the nonprofits out there are going through a lot of rough stuff, and I just want to remind all the executive directors or listeners out there that you have to take good care of yourself first, because you can't help your family, you can't help your employees, you can't help your cause if you're burnt out. And so make sure every day you're doing what you need to do first for yourself, whether that be taking some time for a cup of coffee or calling a friend or meditating or praying or exercising, wherever it keeps you sane, because we need you and we appreciate the work that everybody's doing to make this world a better place. Other than that, I want to thank you for listening to the Nonprofit MBA podcast, and everybody have a fantastic day. I'll see you later.